For those folks entering the webinar, we will be starting momentarily.
Matt, just give us a go ahead.
I will. Okay, Kev, you can begin.
Okay, great, Matt. Well, good morning, everybody. I'm Kevin Law, President and CEO of the Long Island Association. Thank you for joining us. We have a great event with a great panel today. First, I'd just like to share a couple of comments. First, I want to wish everybody a very happy Passover and a happy Easter or a happy spring. It's amazing that about 1 year ago today, all of our lives changed with this pandemic. And we all started Zooming, and we haven't had in-person meetings in a while. But like many of you, I'm optimistic about the future. And I'm hopeful that the LIA will start having in-person meetings again soon. Hopefully in a couple of months, we'll be able to start getting together again, at least in smaller crowds. And so look forward to that. I want to thank everybody who's reached out to me with emails, texts, and phone calls. Tomorrow is my last day as the CEO and the president of the LIA. And today is the last program I'll be hosting. And I'm going to miss pulling these great programs together because they've, in addition to always great networking events, they've always been great educational events for the business community on Long Island. As you know, Matt Cohen, who does a great job for me as our Vice President of Government Affairs, he'll be running the show with our chairman, Larry Waldman, overseeing things until they decide on a replacement for me. And you all know and love Matt. He does a great job, and he'll continue to do a great job, after I leave. And you may have read today, I'm going to a great organization called TriTech Real Estate Development Company. I'm going to be a partner and executive VP there. I'll be chairing their affordable housing team and really trying to make a difference in revitalizing our downtowns and creating much needed workforce housing for our businesses and their employees. So I look forward to continuing that and starting that new role. And finally, after we hear our presentations from our two great panelists, if you have questions, put them in the chat room. And if we have time, we'll get to them at the end of the program. So also, we have two special guests joining us in addition to our panel today. I want to acknowledge former Congressman Pete King, a great friend of the LIA and the Long Island business community, a real champion for Long Island. Welcome, Pete. And my dear friend, John Flanagan, who had an amazing career in Albany in both the Assembly and the Senate Majority Leader, and now is a part of the Northwell team. John, thank you for everything you've done for Long Island and for your friendship. And thanks for joining us here today. So now on to our program. Our two guests, Michael Dowling and Bruce Farber, they have amazing bios. I'm not going to read all of it, but I do need to highlight some really key points. So Michael Dowling is the president and CEO of Northwell. He leads a clinical, academic, and research enterprise with a workforce of more than 75,000 employees with revenues of $14 billion. He's one of healthcare's most influential voices. He takes on societal issues such as gun violence and immigration that many health system CEOs and regular CEOs just shy away from. Northwell is the largest healthcare provider and the largest private employer in New York State. Also, Northwell has pioneering research at the Feinstein Institute for Medical Research, associated with the Zucker School of Medicine, and then the Hofstra Northwell School of Nursing and Physician Assistant Studies over at Hofstra. Great new medical school there. And then last year, of course, Mike successfully navigated the health system through the first COVID-19 epicenter. and he detailed his experiences in a book called Leading Through a Pandemic, the inside story of humanity, innovation, and lessons learned during the COVID-19 crisis. Northwell treated more than 150,000 COVID patients while keeping their employees safe. And even before all of this great work at Northwell, Mike, as the CEO, he was the chief operating officer there. He was a senior VP at Empire, Blue Cross Blue Shield, and he spent 12 years in New York State government as the Health Education and Human Services Deputy Secretary, as well as the Commissioner of the Department of Social Services. Mike grew up in Limerick, Ireland, got his undergraduate degree from University College Cork, and his master's degree from Fordham University. And Mike, if you could hear the audience now, they are all doing a great big applause for you. So welcome, Mike Dowling. And also joining Mike today is Bruce Farber. Dr. Bruce Farber is the Chief of Infectious Diseases at Northwell Health. He's a graduate of Northwestern University's Honors Program in Medical Education, also received his bachelor's from Northwestern, did medicine training at University of Virginia, also served in fellowships at Massachusetts General Hospital, and did further research at the Harvard Medical School, also joined the medical faculty of the University of Pittsburgh. And Dr. Farber joined North Shore University Hospital in 1985 as a senior member of the Division of Infectious Diseases. He's co-authored 45 peer-reviewed scientific papers, edited 2 books, and authored multiple review articles and abstracts. And in addition to his very busy clinical schedule, Dr. Farber is the Chief of Infection Control for numerous Northwell Health institutions. And so, Dr. Bruce Farber, welcome. And again, likewise, if we were here in Melville at the LIA, everybody would be applauding your background and your introduction, but we can't hear them do that today. So we're going to get right to our program. I'm going to first ask Michael several questions and interview Mike. And then we're going to hear a presentation from Dr. Farber, and we'll ask him a couple of questions, and then we'll get to our audience questions. And as always, we wrap up in an hour and we'll finish by 11 o'clock. So let's get right to the questions. Mike, I'll start with you. And let's talk a bit about Northwell Health and describe your experience as a leader during the last year of the pandemic with COVID-19.
Okay, Kevin, thank you so much for having us on. I'm delighted to be here with Dr. Farber. And let me begin by saying special thanks to you for your exemplary leadership of the LIA over all of these years. You have been a wonderful asset, obviously, to Long Island and also the downstate region. So thank you for that, and best of luck, obviously, as you go on to your new endeavors.
Thanks, Mike.
Let me just say a couple of introductory words about Northwell Health. You mentioned a lot about us in your intro, so I don't need to belabor that. We are a health system that has grown dramatically over the years. And one of the wonderful things about Northwell is that we have all components of the healthcare delivery system, which is obviously very, very, very important. And on the COVID issue in the last 12 months, it's been a transformative year. I don't think anybody back in beginning of January in 2020 would have anticipated the kind of a year that we were going to have. But one of the things when I look back on it that makes me feel great is that I have so much pride in healthcare workers and the healthcare delivery system for what was done, because everybody can take credit, but quite frankly, the type of people we have here at Northwell, the staff on the ground, on the front lines at Northwell, did absolutely extraordinary work during the whole crisis, which of course we're still in. It is not over. And Bruce, I know we'll go in and talk a little bit about that. We started to prepare for the COVID issue in January. We knew in January that we were in all likelihood going to get hit with the crisis here in New York. So we had the benefit of preparing well in advance of our first COVID case, which was on March 2nd of last year. So we prepared early. We anticipated that we would have an issue. So we got our teams in place, and we have a good infrastructure here that was able to plan in advance. And while it was hectic during the course of the year, and we had to do extraordinary things very quickly, you can only do that when you have a great team of people around you, when you have people that are unbelievably motivated and compassionate, and who consistently want to do the right thing. So as the CEO of Northwell, I mean, the credit goes to the people around me and the frontline people. And I think, quite frankly, healthcare overall, over the past year, we saved New York. We were at the epicenter. And you mentioned the number of cases that we had of COVID. The actual number of documented cases that we've already seen is over 190,000 COVID cases. Wow. At our height back in April of last year, we had 3,500 patients in our hospitals on a daily basis. That was hectic in end of March, April, going into the beginning of May. It eased off a little bit over the summer, increased again in the fall and over Christmas, where we reached 1,400 cases per day in our hospitals. This morning, we have about 760 cases today in the health system, and that's remaining static now. We haven't had much of a change in the last 2 weeks. So I don't want to go on too long. I know you have other issues, but I feel great pride in the health system, great pride on the people, and the tenacity and the resilience that everybody showed during the last year was enormous. And one last point, the public has been unbelievably supportive here. We had over 1,100 companies and organizations provide support to us, whether it was food, whether it was other support services that they provided to our staff along the way. So the support we got from the community and the trust that was built up between the health system and the community during this crisis was amazing. And so I want to say thank all of those who continue to provide their moral and material support during the crisis. It's an experience, but I think as a result, we will be better off because we've gone through something like this. I think it will make us better at the end of the day.
I totally agree, Mike, and it's great to hear that so many people, stood up and helped you and your team out, and your employees as well as your patients. Did you have any prior experiences that prepared Northwell for this current experience in terms of other, like infectious disease? I mean, we've never experienced COVID before, but were there some things that helped prepare Northwell or you yourself for this task?
Well, I've been involved. Obviously, you mentioned my role in government, and I was involved very heavily in the crack epidemic, and very, very involved in the old days in the AIDS epidemic, which of course Dr. Farber was as well. So you learn every time you go through something difficult, you learn a lesson that helps you for the future. But here at Northwell, we've been very, very fortunate because over 20 years ago, we began to put together a disaster preparedness infrastructure, or emergency management infrastructure, if you want, to prepare us for what we knew would always happen, which is that bad things occur. And you've got to be prepared for when the uncomfortable occurs. So way before 9/11, we put together an infrastructure here, and it had to be used in 9/11. It helped us when we had Hurricane Sandy, Hurricane Irene, H1N1. So we had a number of these events over the years. And in every single one of them, we put in place and managed through our infrastructure, which was very, very sophisticated. And we learned along the way in each one of those. So when we go back to January of 2020, we called our command center. We activated our command center in January when we were observing what was going on in Wuhan and in Italy. And we are fortunate to have such an infrastructure. And one of my recommendations is, and one of the recommendations in the book that we wrote, was that every organization, whether they be healthcare or not, should have in place a strong disaster preparedness infrastructure, because bad things will occur and they will occur again. This will be over at some point, at least the medical part of it will be over. The economic implications of COVID will go on for years. Because every organization is affected by COVID. everybody is going through major transformation today because no company is going back to exactly the way it was prior to COVID, including us at Northwell. So we're working through those issues at the moment. But because we had that infrastructure, we had the right processes, we had the right people, we had our own supply chain infrastructure, which we had put in place years and years ago. That helped us enormously during the crisis. We did not have to worry during the crisis whether or not we were going to have enough PPE. And that was an awful lot written about this and talked about. We were the first entity to require, resulting from our advice from our clinical leadership, to have all of our staff wear masks. We were the first to do this. And we were able to do it and sustain it because we have our own supply chain infrastructure, our own warehouses, etc. So we never ran out of masks, gloves, etc., etc. And so we were, I think, better prepared because of what we've been doing over the past 20 years. We didn't have to make it up on the fly when COVID was about to hit last year.
That's terrific. And are those things that now other healthcare institutions will be able to take lessons from, learn from Northwell? Yeah.
Well, yes, and we've been talking to almost every conceivable group around the country on this over the last number of months, and so has Dr. Farber. And the other benefit that we have, if there is one piece of evidence that demonstrates the importance of having a large health system with all the various components, including a transport network where we were able to move COVID patients from one hospital that was getting overloaded to other hospitals that were that had less problems. That whole transport infrastructure we have, and all of the services we have, the home care, the ambulatory, the primary care, the inpatient, the post-acute, all of that working together. So the systemless nature of what we are and how we're integrated was absolutely effective and proved its work during COVID. If you were a single hospital standing all alone, not part of a larger infrastructure like us, you were in terrible trouble when you have to come up against an issue like COVID. But since we all work together as one, we were able to handle it effectively.
Terrific, terrific. You know, Mike, what are your biggest leadership learnings from last year in terms of the things you think you did best? And are looking back, are there any things you wish maybe you did differently that you learned so you know it for next time?
Well, everything you do, you can always improve on. I mean, you never do anything perfectly. Even sometimes you like to pat on your back saying that you did, but if you're serious about it, there is always room for improvement, as there should be. But I think the major lessons, one is that you've got to take extraordinary care of your staff, and not just only during a crisis, but even pre a crisis. And under normal circumstances, how you take care of your employees is important, because you need their complete loyalty and commitment and compassion and dedication when a crisis hits. So we spent a lot of time, and we did it before COVID, but we spent a lot of time during COVID working with our employees to provide as much support as possible and making sure that we could assure their safety, their comfort, continue to inspire them despite the pressure that they were all under. I mentioned a lesson about having an emergency management infrastructure in place, because that is very hard to do in the middle of a crisis. There's the old story, fix the roof while the sun is shining. It's very hard to fix the roof when it's raining out or you have terrible bad weather. So doing the preparatory work early on for every organization is important. The systemless nature of being able to work, and which I just mentioned, was another great lesson. The other thing that was extraordinary here, and I know Dr. Farber may mention this, is that the innovation and the creativity that emanated from the system and inside the system during the crisis was extraordinary. We did things overnight that, in a non-crisis situation would have taken you months to figure out. But innovation and creativity sprouts during a crisis. And one of the reasons that we were able to do so much was that the governor relaxed a lot of the regulations that we normally are under. So regulatory flexibility with regard to compliance, etc. All that flexibility allows for unbelievable creativity. which leads to a very good question, is that if we want to be continually flexible going forward, we've got to relax the shackles of unnecessary regulation. Because if they had not been relaxed during COVID, we would not have been able to do some of the things. I'll just mention one. We take a conference room at North Shore University Hospital, and overnight we converted into beds, hundreds of beds. Under normal circumstances, I would have been prevented from doing that because of regulatory approvals that would have been necessary. But since those regulations were dispensed with and relaxed, we were able to do enormous flexible things. And so there are wonderful lessons here. And the other lesson that is important is that having a clinical advisory group, which we put together, and Dr. Farber was a major part of this, that advised us on a daily basis about new clinical protocols, new treatments, new ways of dealing with patients, especially at the beginning when we didn't know an awful lot about the virus. But having that clinical input on an ongoing daily basis and being able to communicate it to the staff on the front lines on a daily basis, multiple times a day, in fact, in some cases, allowed us to be able to adapt very, 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 very quickly. And so a lot of these lessons are outlined in the book that we wrote, which was published in the middle of the summer last year, which I think can be a template for every organization, whether it's healthcare or not. There are lessons there that I think if people are interested or watching this, take a look at that book. This is not for the purpose of, making a commercial success out of selling a book, but because we don't, but this is all the lessons there, I think, are applicable to any organization.
And is that why you wrote the book? And was that the first book you've written?
No, I've written a number of others. Yeah, I've done 4 already. But I didn't start out to write a book. It was very interesting how this happened. Everything was happening here so quickly during March, April, and May. And what I would do on the weekends at home is I would jot down in paper the things what happened during the week, the unique things that occurred, the creativity that occurred, and I just write down the lessons learned. Then a publisher reached out to me saying, this is a unique circumstance that we're undergoing. Nobody has gone through a pandemic before. Somebody should write something. So what we did is we took the notes I was collecting every weekend and turned it into what turned out to be a book. I didn't start out to do a book, but as it evolved, it took a life of its own. And then we reached out and talked to people around the health system. And it was turned around very, very quickly. The whole thing was done in about 8 or 9 weeks.
Oh, terrific. Yeah, Mike, I want an autographed copy, sent to my home. And I look forward to reading it.
You will get one. You will get one. But it's instructive, because the other lesson here is that if you don't document these things as you're going through a crisis, you kind of have this idea that you'll always remember. But when the crisis is over, you forget.
Right.
And so the history is important, because as Bruce will probably mention, we're going to have pandemics in the future. We're going to have other uncomfortable circumstances. We're going to have other disasters. And hopefully one of the other large lessons here is both for the government and the state is for us to be able to now learn what we learned so that we can prepare for when the inevitable happens again. Because as a country, we were not as prepared as we should have been, even though the scientists for years and years and years, and the medical people for years, for the last 20, 30 years, have been telling us that something like this was going to happen. But you kind of let it in one ear and out the other. So our job today is to not forget the past year, learn from it, so we be better prepared for the future.
A terrific lesson for all of us. Thanks so much for sharing that, Mike. Let's hand it over to Dr. Farber. I know, Dr. Farber, I think you have a presentation, and then we have a bunch of questions for you as well.
Sure. Can you just pull up the slides, please? So thank you, Michael. And I do want to just reiterate one thing that he said, which is so unique about what happened in Northwell over the past year. And that's that having lived through many, many epidemics, nothing like this one, but HIV was a big one. Unlike H1N1 and unlike HIV, there was no fear among our employees. I can't think of one instance where all men weren't on and women weren't on deck at the same time. So I'd be standing next to urologists who hadn't practiced COVID at all, and they were right there. And in HIV, we had a lot of resistance in the beginning and a lot of shunning of those patients. So it was really a terrific thing. So I'm going to just briefly update you and give you some information, mostly optimistic, but also, quite frankly, realistic and sobering. As you guys know, in New York, things are opening up as they are around the rest of the country, and people are really ready for the pandemic to be over. The question is the virus ready, and what are we going to face? Next slide, please. So we know that we are very dependent upon these vaccines. And let me just very briefly say that these vaccines are a miracle of science. No one in infectious disease ever thought we would have vaccines of this degree of efficacy against a respiratory virus, because we've never had vaccines anything close to this that are effective against respiratory viruses. Flu is the best example, RSV and the like. 95% efficacy in preventing symptomatic COVID, 90% efficacy in preventing asymptomatic COVID, over now actually 140 million doses given, no documented deaths from the vaccine, anaphylaxis at a rate of 1 in 250,000 people, not one single death from anaphylaxis, 25,000 pregnant women given the vaccine, not one single report. And although it is not as good against certain variants, which I'm going to talk to you about, it prevents serious disease from most all of the variants. Not all disease, but serious disease. The J&J vaccine, a similar story, not quite as good, but very good. And most important is 100% efficacy in preventing hospitalization and deaths. Anaphylaxis seems to be very rare. The single dose has advantages, and a 65% efficacy against the 351 variant. Very similar to what's going on in New York, as I will show you. Next slide. Okay, so unfortunately, COVID is not over. And although I think we're going to get back to normal and we're going to deal with it, COVID is never going to disappear completely. There's only been 3 viruses that have ever disappeared from the human race after they've been disseminated. One is smallpox, the second is polio, and the third is SARS-CoV-1, which was the virus that came before COVID that caused SARS about 10 years ago. And that virus disappeared because it just didn't have the ability to infect large numbers of people the way SARS-CoV-2 does. In Nassau County, 18% have been vaccinated fully, Suffolk County, close to 14%, and in New York City, it's about 18%. So we're making progress. Our major problems are the rates vary enormously in communities. Underserved communities don't have these rates, as I will show you. Immune-suppressed patients have not been studied well, and background community rates have not fallen compared to last summer. Although hospitalization rates have leveled off, they have not fallen in the last 2 or 3 weeks as fast as we would like to have seen them fall. Next slide. So this all boils down to one simple thing. The race continues. It's a race of vaccinating people against variants and loosening of mitigation efforts. And that sort of sums up everything that we're looking at. Next slide. So you can see this is the up-to-date data from last week in Nassau County. It's similar to Suffolk and New York City. And what you can see is we had really a great fall between January and February, but we've just not seen it fall in the last 3 weeks of March. It's leveled out, and it's actually higher, as you can see, than certainly our peaks were last summer. Next slide. Again, this is the United States, and you can see that although we're below the summer cases in US cases, deaths are still above the peak of last summer. So we are doing better, but not nearly as good as we would like. As Michael said, there's still over 700 patients in Northwell with COVID. Next slide. So let me tell you about what's really going on now, because this is really what the whole thing comes down to, the variants. So as you have heard, the B117 is the UK variant. And it is inhibited, it is inhibited, excuse me, by the vaccines. So the vaccines work just as well against the B117, but the B117 is more transmissible and more deadly. And that's why we're seeing more cases, even though the vaccine is rolling out very well now. The second is the B351. That's the South African variant. It resists monoclonals, it's partially resistant to the vaccine, and it's more transmissible. Thirdly, the P1, that's the Brazilian one. It causes reinfections in people who have previously had COVID, needs to be watched. And the one that we're obviously facing that I want to explain to you in a little more detail is the B526, which contains the 484 variant. Next slide, please. So look at the cases by variants in the United States now. You see that the B117, which entered the United States late in December, is now spreading all over the United States, which is exactly what people would expect. The most contagious virus will outwin compared to the other variants. Next slide, please. And let's look at how this has shaped up. If you look at February, you can see the B117 accounts for less than 5 or 10% of cases in the United States. But by March 13th, it's now accounting for a significant group. You can see it's the orange or yellowish-like color in the middle. And now we're up to 20% B117. I think most people feel that by the summer, the B117 and our virus will predominate strains in the United States. Next slide. So what impact is this having in New York? Because that's what you're most interested. So we have a variant in New York that is now accounting for 50% of all strains of COVID. Half of the people being admitted to Northwell are having this B526 variant that wasn't around 8 weeks ago. The B526 variant, without getting too technical, is a pair of 2 different mutations occurring simultaneously. It includes the E484 and the 477. I'm sorry for all these numbers, but this is just the way it is. Monoclonal antibodies have no effect against the South African strain that contains the 484. So the monoclonal antibodies that we're giving to every patient who have early COVID and are at high risk are now losing their effect against about half of the strains circulating in New York. Next slide. So what are we going to do? Well, this is clearly the future. The first trials have begun about 2 weeks ago. Moderna created a new vaccine that covers the 451 and includes that strain that is infecting New York. And they gave 20 micrograms, 50 micrograms, and a new multivariant booster, meaning it's the regular vaccine that we're giving out now, but it has an additional variant cocktail in it. And the first studies have begun about 3 weeks ago. It'll take a couple of months to see the results of those studies, but this is the future. This is what we're going to have to be doing all the time to keep up with these variants. Next slide. Let me just show you the breakdown in New York City of the people who have received at least 1 dose of the COVID vaccine. You can see that Asian and white people have gotten higher rates of vaccines than our Latino and Black neighbors. And this is something that we need to work on, and Northwell is working on. You can also see that the Bronx and Brooklyn are underperforming compared to Manhattan and Staten Island with regards to these rates. You can break these rates down by zip codes, and you will see that the underserved communities, all by zip codes, have less vaccination rates than the higher income communities. Next slide. You can also break it down that there are over 1.2 million New Yorkers that have been vaccinated who are over the age of 65. That's about 70% of New Yorkers that are over the age of 65 have not been fully vaccinated, but we are getting there. If you notice, the dark areas on this map show the percent of people who have been vaccinated, and you can see parts of Brooklyn and most notably the Bronx and Eastern Long Island have the least acceptance of vaccination among 65 and older. We can talk about the reasons why if we have time. Next slide. So what's the future? the future is that FDA approval of this vaccine is likely in the next 6 months. Remember, we do not have FDA approval for any of these vaccines. Without FDA approval, Northwell, the Jets, the Islanders, the schools will have a great deal of difficulty requiring its employees to take the vaccine. But mark my words, once FDA approval occurs, you will see that very rapidly. Rutgers is the first university in the United States to announce that they will not let any of their students matriculate in the fall unless they've been vaccinated. You will expect to see that all over commercial industry somewhat down the line as soon as this is FDA approved. The airline industry, which I spend a lot of time on the phone with and conference calls, is gearing up for their passports that will require people to show they've been vaccinated to get on it. They want to build their business back, and they need the safety of their planes to get customers used to traveling again. As FDA will allow employers to require vaccination as a condition of employment as long as no health screening is required. And the courts have already ruled on this. What they've said is that a company like Northwell, for example, would be able to require its employees to get the vaccine, provided they do not ask any individual employees anything about their past medical history. So you're not going to be able to cherry pick or pick and choose that certain people can get it, other people are not going to get it, and the like. But I think that that's happening. That's going to be the future. Vaccine boosters, vaccine passports, and ongoing testing will be a permanent fixture for years. COVID will be around for years. People think, well, after COVID, well, I think virtually every infectious disease person thinks, well, there's never going to be an after COVID. We're going to deal with COVID. The question is what's going to happen next, which we have to, be aware of. But COVID's not going to go away. There's 6 billion people in the world that we live in. They're not all going to get vaccinated. There are variants that are going to break through, and we're going to just have to deal with this. Mitigation efforts will continue, but in my opinion, there will be a significant de-emphasis on the disinfection surfaces and other sites. Remember, last March, COVID was thought to be caused by 3 mechanisms. Disinfection, meaning touching things. Remember, people were afraid to take in their Amazon packages. They Purelled to death. They, disinfected everything that was around. And then there's the airborne spread, and then there's the droplet nuclei. Well, I think every month that has gone on, people realize that the contact mechanisms of transmission are few and far between. The CDC has come around to believing that. The airlines are slowly believing that. Industry is slowly believing that. And that's good for everyone except perhaps the disinfection industry that, had a field day in selling everybody, the idea that everything you touch has to be cleaned immediately. It's just not how things are spread. The original studies that looked at COVID surviving on surfaces were done with super physiologic doses, 10 to the 9th organisms, and then they saw that they could live for 24 hours. Those were not physiological numbers that anybody encounters in real life. And so that's one of the things you will see down the line, a little bit less Purell. Next slide. I think we can finish up the slides. Great. So I think we left some time for your panel discussions, and I'll be happy to answer any questions that I can.
Great. Well, Dr. Farber, thank you so much. I was thinking in my head, who is Dr. Fauci? I mean, you explain things better than I've heard anybody explain things. So that was terrific. And I'm sure our listeners will enjoy that. And we're going to blast out, we're recording this panel. We're going to blast this out to people all over Long Island as well. So they'll be happy to hear those comments. I've been optimistic for the last month or so, given the fact more and more people are being vaccinated. You sort of got me concerned again. Are you still optimistic, that, as I said, we're not going to beat this thing, but we're going to be able to deal with it? And are you optimistic over the next, say, the second half of 2021, that things will get better?
Yeah, I'm very optimistic. I'll tell you the areas that I think we should all have concern about. I don't believe the variants are ever going to cause a pandemic. There will be enough baseline immunity that they will cause disease, but I don't believe they will cause anything like what we had last year. So I'm very optimistic about that. Quite frankly, I'm very nervous and upset about the vaccine hesitancy. Even among our own employees, but in other industries, wherever I go, I see 20%, 25% of people who come up with a variety of reasons. They don't know what's going to happen in the future. Well, I can tell you what's happening in the present. Stop worrying about the future. 550,000 people have died. They're worried about fertility. There's no issue regarding fertility. They're worried about pregnancy. There's no issue regarding pregnancy. They're worried about everything except what they should be worried about, which is COVID, which is here and now. And we need those people to have enough baseline immunity to prevent the emergence of more variants. People say to me, I had COVID. I don't need the vaccine. I say, you're going to get COVID again 6 months. The immunity from COVID only lasts 6 to 9 months. The vaccine-induced immunity is much better than COVID-induced immunity. It's one of the only 2 infectious diseases in the history of man where vaccine-induced immunity is better than natural-born immunity or wild-type immunity, as we refer to it. So those are my concerns, that, that we need to sell this vaccine. To me, it seems like such a no-brainer, to be honest. But
Right.
yet there's resistance. I take people from dietary, where we've had very poor uptake in the vaccine, from environmental service. I visit those places on a regular basis. They know me well. They're tired of me coming down, but I'm still asking them about vaccination. And I think we need to keep pushing and pushing and use carrot and sticks, quite frankly, when we can, as other industries will be doing.
Got it, thanks. And when you were referring to boosters before, do you envision like our future that we'll all be going into Rite Aid and Walgreens and getting a booster shot like we do a flu shot now, or whether we go to our physician or Northwell or et cetera? And do you see the supply of those boosters being available, that there won't be this registration requirement and a wait list and an eligibility list, that people will just automatically get these boosters like they do flu shots?
I think ultimately that'll happen. I think places like Northwell, I mean, this is going to be a new little infrastructure that's going to be around. I mean, I don't think people are going to be able to do this with 300 million people in their doctor's offices. I mean, one of the things we learned is people don't have primary doctors. They don't have access in underserved areas. We needed to set up vans to go to these underserved areas. So I think there's going to be a role for health systems to continue to coordinate this. Yeah, I don't think there'll be the lines that we had this time, but this is, going to be an ongoing responsibility. And I don't think we're going to be able to leave this to Walgreens and CVS and primary care doctors. It's too big. I mean, look at the influence, look at flu uptake in our communities. It's not very good, quite frankly. We're going to have to do a lot better with COVID, and we're going to depend on things and infrastructures that weren't there the last time around.
It makes sense, and also good to hear. Also, one of your slides, you were talking about the distinction between FDA approval and all the vaccines that are out there now, that they have this preliminary or conditional approval. Are there, what are the major steps between the conditional approval that they have and the FDA approval? And do you think once the FDA officially approves these vaccines, we'll see a spike in participation?
Well, there are 2 questions there. And the answers are the following: that the FDA is going to approve these vaccines. I don't think there's any human being who doubts that. The only reason that we haven't gotten FDA approval is by law. They are required to wait at least 6 months, and they've never licensed a vaccine prior to a year because they don't know how long the immunity is going to last, nor do I, quite frankly. And although we all think that it's going to be at least a year or 2 or 3, they're very scientifically and data driven. And since the vaccine has only been out 6 months, the FDA cannot guarantee any immunity after 6 months, because that's all we're up to. So they're dragging their feet on that issue, and they will undoubtedly approve this. The question is, what's their approval process going to be, and when will it come? The second part of that question is, will people take the vaccine if they think it's FDA approved? I'm not sure that that really matters. I'm not sure that people know the distinction, quite frankly.
Right.
It's hard to know.
Got it. Is there a big distinction between the Pfizer and the Moderna and the J&J vaccines? And in a layman's way, how do they work, and how do they work differently? And is one better than the other, in your opinion?
So another reason why a place like Northwell will have to be involved in vaccinations is because the logistics of using a Pfizer vaccine, which is one of those best vaccines, is not anything that an individual physician or even a drugstore chain can do on a regular basis. I don't want to waste the rest of your time explaining why, but even if you have a cold chain, there are requirements of once that vial is popped open, you only have 2 hours to use those doses. It's not something that an individual physician in their office, unless they've scheduled 10 people ahead of time, can do. Quite frankly, most of our doctors don't want to go near this. It's so cumbersome. Every patient has to be registered in NICIS, a state database. It's time consuming. It's a huge effort. So I don't think that, our primary care doctors, other than those employed by a system where they have a huge backup, kind of like what Michael said, as a single physician, which is quite frankly a dinosaur nowadays, but nevertheless, they're not going to get into this business. This is a tricky, difficult, and technically problematic visit. You think they want refrigerators that have alarms, that have backups, that have generators attached to them in case the power goes out. They have to have alarms go off if the temperature changes. You have to have careful regulation of how every dose is given. It's got to go into a database. So to make a long story short, this is not something that you want to try at home, as those TV commercials say. This is for
Right.
professionals. The second part of your question is, what is the difference between Moderna and Pfizer and Johnson & Johnson? In brief, the Pfizer and Moderna vaccine had better efficacy, about 95 compared to 75% in preventing COVID. They both have good efficacy in preventing asymptomatic disease, but Pfizer and Moderna had better. But on the other hand, Johnson & Johnson prevented all hospitalizations and deaths. So for many people, it's a great vaccine. It's a single dose vaccine, although their 2-dose trial will come out soon. But it's a great vaccine for people who can't get out to these centers. We're using it in home care. We're using it for the homebound. It prevents hospitalizations and death. And I think you should get whatever vaccine you can as soon as possible.
Got it. Hey, Mike, do you how do we break down the mistrust or the misinformation out there about people not being vaccinated? And have you ever, in your experience, seen the vaccination process so politicized?
Well, it's been a complicated process up to this point, and it mainly because of the supply. I mean, when you have a small supply of the vaccine, then you got to make decisions about who's eligible, which group should come first, which group should come second, which group should come third. And that's been very, very complicated. And the systems that were put in place to allow people to register were not as effective as they should have been. We now are at Northwell alone, we are now have an infrastructure that is able to do up to 100,000 vaccinations a week. And we fully expect over the next couple of weeks, when the supply increases, which is anticipated, that we will get to that level. Right now, we're doing about 40,000 vaccinations a week. And we have about 45 locations out there. And we're focusing heavily on the poorer communities and the Black and the Hispanic communities. And we're out there dealing with the pastors and the local leadership. And we have an equity task force. So in answer to your question, I think is continuing education. There are some people who are hesitant to take it because they were wondering what is the reaction to the vaccine. I'm going to let you take it first, and then when I see what happens to you, maybe I'll take it. So it's a continuing education, and we need leadership in those communities that are disproportionately affected by this and where the high hesitancy rates are. Those leaders have to be out there saying the science works, the process is appropriate, it prevents you from being hospitalized and prevents death. But also remember that you will end up, and then Bruce, I would assume, agrees with me on this, you will end up with probably close to 20% of the people eventually not getting the vaccine. Remember, even with the flu shot, I think in our health system, we've never gone above 85% compliance with the flu shot. So you do have that core component of people out there. And I don't know any way to deal with it other than to continue to provide access, go out into the communities, use local leadership, educate as much as we possibly can, break down the myths, and everybody, including everybody that's listening to this, they should become ambassadors out there to say to people, To protect yourself, protect your family, protect your neighbors, you need to do what's right. And doing the right thing right now is getting the vaccine. And I think it's just persistence.
Do you think employers, or large employers here on Long Island, should mandate that their employees get vaccines, given any exceptions for religious beliefs or other health issues?
Well, let me turn to Bruce on that question. Bruce?
Well, it certainly can't happen now. And certainly Northwell and the system is not going to do that until the FDA approves it. It's not even conceivable to even talk about that. And it's obviously the last thing that people want to do, but it's, I think, ultimately going to happen. It's happening in other countries. And, you know, what's happening we had a great lecture from Israel a couple of weeks ago, and we saw their green passport roll out. And what they're doing is they're saying, you know, we're not forcing anyone to get vaccine, but you're going to have to show this green passport to get into a restaurant. And you're going to have to show this green passport to be a member of our sports team, to play intramurals when you're in school. And so it just keeps making, you know, doors open for you when you get the vaccine, and doors are going to keep closing on people when they don't get the vaccine. And hopefully that will continue to push people.
Got it. Good. You know, I'm sorry, Mike.
I do think that if people end up, especially in healthcare, if people end up deciding they just don't want to take the vaccine, then we will obviously have to have restrictions in place, especially for those people that are dealing directly with patients. We don't know what that is yet, but we will be having discussions on it.
Makes sense. One of our audience members, first, all of them are thanking you all for the extremely informative information. And one is Mr. Dowling. Can smaller independent hospitals or hospital systems or other healthcare organizations take advantage of the larger health systems like Northwell's infrastructure to better serve their patients?
The answer is yes, and that's what has been done. So all during last year, and still in effect, some of the smaller places and the places in that were not necessarily connected formally to any place, we actually adopted a bunch of hospitals over the last 12 months connected to us, where we would provide ongoing support, ongoing backup services. And I was able to assure the state that if those hospitals got into any trouble, that we would be there to back them up, which we've done. So the answer to the question is absolutely yes. We have an obligation here, because you want to get over this. You want to end up being out of this crisis at some point, and you don't want any hospital that is near you, whether it's part of your system or not, causing a crisis that expands across the community and affects everybody. So yes, we adopted a whole bunch of facilities, and so did the other big health systems, by the way, in the New York area. We all adopted a bunch of people, a bunch of entities that were not formally connected with a large health system. So the answer is absolutely yes. Our philosophy here is that we provide as much help as we possibly can to everybody who needs it. And we do that under normal circumstances, and you especially do it when you're in a crisis like this.
Got it. Dr. Farber, you were mentioning before that people who have COVID can get infected again. For people who have had COVID, should they get the vaccine, and how soon after they've had COVID should they try to go get the vaccine? Any thoughts on that?
Yeah, I mean, the answer is yes. They definitely should get the vaccine if they've had COVID. They have to wait at least 10 days so they're no longer contagious. That's our bare minimum. They certainly have 3 months, and the CDC has recommended that there's no urgency to get it for the first 3 months. But yes, they should get it. There's no question about that.
Yeah, but so maybe for 3 months they may be okay, but they should get it afterwards. I'm asking a personal question. My son had COVID up at Mike's alma mater up at Fordham. The Bronx is some of the highest infection rates in the state, and he had 2 bad days, and then he was fine, isolated, everything. But he was going to head out next week. I was like, you should be careful. And him and that generation, they're like, oh, I've already had it. I'm good. I'm protected. But he's really not. And he should still be careful. And he should get, when he's eligible, when the 20-year-olds are eligible, he should get the vaccine, correct?
Yes.
Got it. Yep. Very good. What can you tell us, Dr. Farber, about the AstraZeneca vaccine? How does that differ from the 3 that already have the conditional approval? And they had a hiccup of late and regarding some of their testing. And are you concerned of how that may impact people's willingness to get the vaccine?
Well, the AstraZeneca vaccine has been a series of unforced errors. Quite frankly, they have a terrible relationship with the FDA. And that has to do with the fact that they changed the goalpost after the trial was started, which is a golden rule of something that you never do in a drug that you want approval for in the United States. The only reason that they're considered it is because we're in the middle of a pandemic. I won't go through all the mistakes that were made. It also failed in the South African trial. And so the vaccine, I think, is a good vaccine. And quite frankly, we need that vaccine, not in the United States. I doubt it'll ever be given in the United States. I don't know for sure, but we're probably not going to need it. But quite frankly, you know, our vaccine is great. But look, France has a 4% penetration rate. I have 2 colleagues in Kenya that I email with. There's 0 vaccines that have been introduced, 0 in Kenya. They're waiting for the AstraZeneca vaccine. South Africa, where it can't be used, has almost a 0% vaccination rate. There are many, many countries in Southeast Asia. So we need that vaccine. It's basically a good vaccine. No, I think it is inferior to the J&J and Moderna. But again, you know, you can't use a vaccine that has a cold chain in Africa. We had difficulty in getting MMRs there because there aren't enough refrigeration sites in some of these villages. Forget a vaccine that needs ultra cold refrigeration or needs to be only stored for 2 weeks. So the reality is it's a good vaccine. It's not quite as good. I doubt it's ever going to be used in the United States.
Got it. Another question from our audience. What is the best source of information or education for those who want to understand about the vaccine and try to convince some of their own family members who are hesitant to take the vaccine?
Well, go ahead, Michael.
Dr. Farber.
Thank you, Michael. I mean, there's so much information out there. I mean, literally, I spend every night spending hours trying to keep up with things. But, you know, I think now that the CDC has, good leadership, I think that their guidance is, for the most part, on the mark.
Got it. Got it. Well, listen, we're just about at the witching hour of 1 hour. Mike, leave final words to you, and then we'll close with Dr. Farber with any final words.
I would say that in a situation like this, one of the things that is extremely important is to be optimistic. You know, you have to be optimistic when you're in a situation like this. You have to believe that you are going to win, you are going to succeed, we are going to move forward. But it's also very, very important to understand, and it goes back to what Bruce just said, this is a global pandemic. And until the world overall gets access to the vaccines, then we're always at some element of risk. Even though we do great here, if other parts of the world are not up to snuff over time, that you're not ever going to be completely out of the woods. But I think that right now we're doing well. I think there's a good optimism. And I think what we will be focused on over the next, going into 22 and beyond is how to get the economy back working. Because the economic effect of COVID on families, loss of jobs, et cetera, is something that we're going to be dealing with for a long time, even if COVID recedes into the background as a medical disease.
Absolutely. And Dr. Farber, your closing comments, could you also weave in there an answer to another question? Should people continue to wear masks after they're vaccinated?
Yes, they should wear their masks, particularly when they're in public. They can take their masks off if they're in a family or in a restaurant eating with people who have also been vaccinated, but they should certainly wear their masks in public for a variety of reasons that, I won't go through now. And I just end by saying that throughout this pandemic, I can publicly say that Michael has been such a source of leadership for the health system that knowing that he's had our backs has really helped people enormously. And it's really very, very, very impressive having lived through it.
Thank
Well, amen, Dr. Farber. Mike, really, you are, you're a leader not only on Long Island, in the state and the country, and it's been really impressive to watch you and your team and all the frontline workers at Northwell. You guys are so critical. You talk about the economy to not only the Long Island economy, but the statewide economy and really part of the national economy. You're really doing God's work. And again, I thank you for your participation in this panel. And again, wish you all a very happy Passover and a happy Easter, and look forward to talking to you soon when I'm wearing my newer hat.
Thank you, Kevin.
Thank you
Appreciate
all.
it.
Be well. Stay safe.
Bye, guys. Thank you all for joining us.